Welcome back, everyone. So we have Commissioner Groves with us from Department of Vermont Health Access and ready for your budget presentation. So take it away.
Take two. So this morning we'll give you a overview of DVA, the both our admin and program budget, somewhat our one-time funding request, and hopefully, if time allows, some key accomplishments from this past year. As the secretary laid out earlier this morning, the budget process was a joint kind of done by the joint executive leadership team. And really kind of focused on our priorities of around housing, substance use, and mental health, healthcare affordability, and sustainability and equality. With that, we really kind of shared that kind of one agency, the shared responsibility. These were hard conversations that we had, but we came together because we realized each one of our departments plays a significant role in the healthcare. For DVA, our mission values, you may have seen these that have not changed. Our mission and values have not changed. But what has changed is that I've been here for a year and a half now. And so I figure we'll shake some things up a little bit. I listened, I learned, I came to stakeholders with an open mind before making any sort of changes and really felt like where should DVA go in the changing landscape that we see both federally and at the state level. And for us, really kind of thinking about kind of three priorities that are kind of outward facing. Those are championing member-centric excellence, really thinking about how do we serve Vermonters, striving to put the members first in everything that we do, thinking about the policies and the programs and how that impacts the members, and really kind of guiding our operational decisions there. Second is promoting a high quality provider network. Coverage is not enough. We know that we need access to providers and making sure that we have an enrolled provider network that has, and then the third one is advancing population health and quality improvement. Thinking about the whole health of a person, not just the medical bills, but just kind of how do we ensure members have access to preventative care like checkups and screenings, and then making sure that the providers have the tools that they need in order to serve our beneficiaries. The last two are really kind of inward facing in terms of making sure that we can accomplish those three. That's strengthening our operational infrastructure and system modernization. And it's important, and that's how we operate behind the scenes. And the last one is finally, none of this happens without the people that work for DVA. And so while it may be our last priority, it probably is our biggest one, ensuring that our staff are trained, that they're building into leadership, and that they feel like they have a place to work and stay, and that they are supported. DVA serves a unique role in the Vermont's Medicaid program. It serves both as the Medicaid managed care and also has core Medicaid program functions. And in this allows us, this dual identity allows us to directly align our policy, financing, and care delivery in ways that other states who have separate kind of managed care health entities as well, different. So it requires DVA to kind of balance regulatory oversight with the operational accountability, ensuring that Medicaid not only meets the federal standards, but functions effectively as a health plan serving the Vermonters every day. And then, so turning to our budget, for those who want to follow along in our budget book, we'll start on page 47 of the book. And I want to point out that the numbers reflected in the PowerPoint represent the totals across all the DVA sections in the ups and downs. So what you'll see is a more accurate number, but we can also we can also go to the ups and downs spreadsheet if we need to. And just as a reminder, the agency was managing about a $7.4 million shortfall. So this is what shaped the aspects of the budget. We have not proposed new initiatives beyond what are required by federal and state law, and we are recommending several reductions to that. So in terms of staffing, this reflects the impact of the PAY Act It's the annualization of the 8 new positions in VCCI who will go out for justice reentry. So they are the ones who go out to the corrections and meet the patients who are eligible and help plan care before they come out and coordinate that post afterwards. And then the benefits and then the vacancy savings, Diva's current vacancy and turnover time is running just over 5%, which is above the 3% level that we currently have budgeted for.
Is this the position or the program that we got an 1115 waiver for last year? Just
The VCCI
Yeah.
positions, yes.
to support people before they're released from corrections and then supportive around services afterwards. Okay.
Any other question?
So there's only, you have 1.61 here, general fund, 137 gross, that doesn't. On your slide in your book, you have them reversed. Is it supposed to be 1.37 general fund, 1.61 gross?
It is. No, that is correct. And I think that's because of some interdepartmental transfers that you're seeing that lower gross.
Okay, thank you.
Turning over to contracts, one of the things that we did as an agency that the secretary mentioned earlier, we're making those kind of difficult decisions of looking at efficiencies. And one of the contracts of the Vermont Legal Aid Medicare Assistance Advocacy Program contract, and where the contract is meant to recoup Medicare funds for dual eligibles. However, over the years, we have consistently paid more for that contract than what we have gotten back from Medicare. For instance, our return on investments in 24 was 60%. In 25, it was down to 15%. And right now in 26, we're running through the end of December, we've gotten around 47%. So we're consistently paying more in that contract than we're actually benefiting from.
Go ahead, Lori.
So if, I guess my question is, do we know why that is? Is it it's whatever, I don't know, but it could be fun, but do we know why? And if we don't do it, what's the negative effect of not being able to recoup any Medicare funding?
So we'll still be able to recoup Medicare funding because Diva internally has a coordination of benefits unit that does some of its work too, but it does the work too as well. Alicia, do you want to speak more
To the why?
Sure. I think there are a few reasons that I've heard about, and I will admit I'm not a deep subject matter expert here. But I think there have been sort of increasing challenges over recent years with greater presence of Medicare Advantage, also affecting how providers are able to interact with the sort of billing and recruitment processes. And I think that if the contract were to continue, that's something that we would certainly work on in conjunction with the vendor. But as the commissioner noted, it is an area that we identified when we were reviewing our full slate of contracts, where we were not sort of equaling our expenditure with the recoveries that we have seen in the last several years.
And are you concerned that with most of Medicare Advantage leaving Vermont, that why won't continue to be an issue?
I think it's possible. I don't think I want to speculate too much.
And were they notified of the cancellation and did they provide any feedback?
It has not been canceled. I
Well,
think
the proposal of the cancellation.
we did not discuss the proposal of the cancellation in advance because it was part of the executive privilege with the governor's development of the budget.
Okay.
The next set of contracts is an increase of 27,000. General fund, these are contracts to help support our chief medical officer. We have two contracts, one for on the mental health side and one to handle kind of pre-authorizations for us. And so that's just an increase in those two contracts that we have for our medical officers. The next kind of set is for our IT systems. We have the MMIS, which is the Medicaid Management Information System, which is our core claims processing contract, and that has updates and maintenance. The second one is our cost center contract with Maximus. And then the HEDIS contract, we are recommending discontinuing our HEDIS measure, which is our quality measurement. That helps with our quality measurement calculator quality measures. The MD-WAS, the Medicaid Data Warehouse Analytical Solutions, now has the ability to provide those measures. So we've been looking at our kind of where we are, where there were duplications in our efforts. This is one of the contracts that we can cancel.
Talk about the MMIS updates and maintenance. This is up. What is the whole contract?
Allison, do you have the whole contract?
No, I don't have it at my fingertips, but we can take a look and we'll find it.
We can get that number to you.
Okay, let's do that. These perennially show up everywhere in BAA, in budget, and just wondering what we're getting. Leslie, did you have a
Yeah, I'm just curious about the HEDIS contract. Those measures are frequently used sort of beyond us to, get insurance. I'm not exactly sure, but I know they're used as important. So does the MD-WAS provide the exact same service outside of AHS?
So MD-WAS will be able to calculate those. That's right.
Internally, I'm wondering about the external world. Does it serve the same purpose?
Yeah, so for the state, it's able to calculate the HEDIS measures and we're able to send that out and that's able, and we use this HEDIS contract to report out to the Fed, to people like the Feds. And so that is one of the things with the MD-WAS, we're now able, and that was what this contract was doing, was just calculating the quality measures for us. And so with the MD-WAS, we are now able to do that internally and therefore we don't need that contract anymore.
So but does the MD-WAS data provide the same information externally to the Feds and other places that we need to use HEDIS measures that we have been?
Yeah, it allows us to, part of the functionality of MD-WAS is to provide reporting to the Feds and external and other.
So that's
partners.
a subject.
Yeah.
Thank you.
Can I just ask real quickly back to VLA? You have it that you're canceling their contract. What is their contract through at this point? What date?
It's through. Do you remember when it's through? I think it's a 5-year contract in which we procured it in 2025. So 5 years would be until 2030, 2029.
So we just renewed it?
Yes. By statute, we have to have this contract and we did not know whether this was going to go into the government proposed budget. And so we had to have a contract for this year, for 2026.
Go ahead, Lauren.
So if it's in statute, do we need policy language to take it out of statute?
Yes.
And is that being recommended to us
Yes.
soon?
Is it in the budget?
It's in the budget.
On the record,
Okay.
Tracy Upon, yes, it is in the governor's recommended thing to.
Language, okay. Can you just let me?
Yes, to
Thank
the
you.
section number.
Yeah, thank you.
Go ahead, sorry.
And then turning to the ADS held budget and contract that we have the MD-WAS, which is annualized for maintenance and operations. with the Deloitte contract, we discussed this in the VA testimony. We have the Oracle licenses, which then has an increased cost. And then again, we have another, the MMIS Gainwell contract there as well.
Can you just remind us what MDWAS is, what MMIS is, what are we getting for this? What is this?
Yeah, so MDWAS is the Medicaid Data Warehouse and Analytical Solution. So this brings together other data sources in Medicaid data. And it's one as a data lake, and then also has the functionality to run reports for like our business offices, for federal requirements, for other reporting requirements as well as being able to kind of have a kind of develop dashboards. So we could dive in and look at our populations and see what's going on, what the services are, what their costs are. And this adds on to our kind of more, gives us the addition, the value add of having an analytical component that we really need.
Is this stacked on top of another system? Is this? I guess my other question is, because when did it go live?
So we have pieces of it going, the analytical pieces going live, I believe last year, at the beginning of, or at the end of last year, we had the analytical pieces going live. And so this is also in partnership with the Office of Healthcare Reform in their health data unit as well, where they have done the design and development implementation, and now we're taking over the maintenance and operations of that.
We done anything with the data we've gotten yet?
I think it's still new. I think some of our staff are currently being trained there. We have run our kind of PMSIS, which is what we report to the feds. We have done that. We have sent that over to the feds and gotten a good response back from CMS on that. So we are seeing a return in our investment on MDWAS, and we'll continue to see that.
Okay.
And then you had a question about MMIS, right?
Yes.
What is it?
Yeah, and how does it interact with MDWAS?
Yeah, so our MMIS is our core claims processing. So, and then also in other functionalities as well, but that's kind of how we process provider claims to us, and we pay that amount in simple terms.
State Medicaid programs are required to have an MMIS.
Yeah.
And then the claims data from that MMIS are connected to that Medicaid data warehouse. And so that's one piece of the data that's going into it. So that they do have a close relationship. And I believe one of your earlier questions was about the costs of the MMIS updates and maintenance on the prior slide. A portion of that relates to the work that the MMIS vendor has had to do to sort of move its data into the data warehouse and support that effort.
Okay, right.
Once did you call it a data lake?
Yes.
Once the data lake is fully open for voting, so to speak, or whatever, open for access, can you in real time be monitoring the health of Vermonters in the Medicaid system? Like, could there be regular, could there be I'm not saying we would necessarily want the public to see this, although it wouldn't be the worst thing if it included everyone, but because it's not fair that only one portion of the population we would know this for. But like, imagine if there's like a dashboard where it can show like, what's the current rate of heart disease? What's the current rate of depression in this, like in the claims lake or whatever, like, is that possible to be tracking?
Yeah, and those are some of the kind of clinical dashboards and cost dashboards that we've already established. Like they're out there and they're for internal use. Like we can see them.
Yeah. Okay. See, that's cool. I think if everyone was included, I would advocate for it being public, but I don't think it's fair if only 30% or whatever of the population's health info is out there. It just doesn't seem right, but it would be cool if we could all just monitor that. And then we could how do we all work together to get our depression rates down, But the other thing is my perennial question whenever technology comes up, which is how might artificial intelligence be integrated into this at some point to improve the functioning of DIVA?
Yeah, and that, I don't think we thought about how to integrate AI.
Do you, I'll let it go after this, but do you work at all with the division of AI in ADS or with the AI director?
I don't, not, there may be some conversations within our Medicaid enterprise program, conversations that they're having there, but I am not aware.
Yeah, I wonder, I think the reason I ask is, and then we can move on, is I wonder if in the future, there might be ways that ADS, through its support of Diva, might help figure out ethical ways to use AI to process data, share data, and apply data. So, thank you.
Can I have some information which you won't have here, but I would like in the future? So the contract with Deloitte, how long is that? When was that done? 2022, 20? Whenever. It would be nice to know what the original contract was and how much we have spent so far up to this point with Deloitte
Okay.
on that. Topper, did you have a question?
Yes. Where was Diva located
We're,
prior to people coming back to work?
so Diva is located in Waterbury in the
Complex?
complex.
Okay, why didn't it go back in there?
Because of space. We did not have enough space for Diva to return. As part of VDH moving into the complex, we gave up some of that and moved into the Pilgrim Park location, or we will be moving into the Pilgrim Park location in February, either February or March.
Did you want to address that? We haven't gotten to that yet.
Oh, no, we didn't, did we?
Okay. Topper was giving us a preview.
Oh, I thought we were on that page.
No, oh, we are, but we hadn't gotten to that.
We're on that page, but thanks, Topper, for the intro. Also, in our operating expenses, you will see the new lease space for 159,000 general fund. That is for the new space over in the Pilgrim Park, so just across the street from the complex in Waterbury. And I think, Leslie, last time you had a question of who we were contracting with, and it's the Malone Superior LLC.
Thank you for including that. Could you just, I'm not sure what the gross and the general fund, what's the gross, where's that other money coming from?
Is that federal money?
Yeah.
You get a match on rent?
On rent or leases?
Wow.
That doesn't,
Rent, I think, is part of admin, so it can be.
so it's coming from a different part of their the budget?
Rent's usually admin, so there's some of the magical, but like other things to be magical under the admin piece and not under the regular match. It's probably a mix.
Yeah, it's a match.
50-50 and then unmatched in other areas, so it's a kind of a mix, which is why it's not perfectly.
Is
I still don't
there,
get it.
So what happens if you allocate the work that's being done on behalf of Diva, they can, or Medicaid specific, be 50-50, but if the work that's done that's outside of the waiver, or only have pure general fund, then they can't match the admin to that. They have to allocate their time when they do the outside the resources. Like imagine if you were using your home office, right? And you were saying, okay, this is time that I'm billing for my work, and this is time that I'm doing my watching TV, right? You can.
Like when you declare on your taxes expenses, you wouldn't say 100% of the expenses because you're not using it 100% of the time for work.
So it's kind of like that, and that, but it's waiver and not waiver. So things that are waiver, we get match on. Things that are not that are such. There's a lot of
Rent?
Medicaid that we do, they're state only. And so
But
that's.
the rent is like that too.
Yeah, everything.
can I ask a question? Did the fact that there is a federal match on it play into the decision that it was Diva as the one particular office that was moved?
I'm not sure. I was not aware of those conversations then.
I think I see your point though. Like there might have been an advantage to having Diva be the one if there's a federal match, and that it would be nice to know if that's the reason why, because then maybe I would be less sassy.
I think-
Other governments do that too. It's not.
Okay.
Yeah, I would contact BGS and AOA. Because those are
Didn't we already go through this with you? Sorry. I feel like we had this, we tortured you already on this, sorry.
Actually, that goes,
But-
distinction.
But I do have, it's in our ups and downs. So 159,000 is the general fund. There's a federal match of 202,000 or 203,000. And then there is a global commitment investment fund. So that's how we get to the 441. So there is a match, but it's coming, as Nolan said, it's coming from different places.
I don't want to keep harping on this, but I would like to ask the question. What was the goal of returning to the office? What was the reasoning for why state employees needed to return to the office? Or what was given as the reason?
Yeah, so the reason we're returning to office is because of to promote kind of in-person has a unique factor of collaboration. And so that you may not get on a virtual in the remote setting. And so that is the reason why we're moving in, because to enhance that kind of that personal interaction and the collaboration between that there may be conversations that you may not have over in a virtual setting.
Would that lead to efficiencies?
They may, yeah.
Are those efficiencies reflected in this budget anywhere?
I wouldn't say,
Collaboration, are they reflected in the budget as savings?
I'm not sure if we would have collected or shown those in the budget as efficiencies, because we're not sure of what these would be yet.
Go ahead, Brian.
Just two other questions about this. One is, I feel like it's maybe more of a reflection back that when you said that bringing people together, I'm wondering if I'm wondering this without expecting an answer, because it's probably something you couldn't answer easily, but like, could it be improving the health of the workers to not be isolated as well? Like, in other words, the social determinant of inclusion and social contact and like being in an office together, could that be better could that improvement in the health of workers then improve the functioning of the agency? I guess, who knows, right?
I mean, I think that would be some speculation. I don't know if I could answer that.
Yeah, and then can you explain the Pilgrim Park thing? Like, is that just the name of the?
Yeah, Pilgrim Park.
They named their building Pilgrim?
Yeah, the campus over there is called Pilgrim Park.
Okay.
For current copies to be.
I know, I'm just having
Yeah.
images of
I
like
know.
people in black hats burning witches and like driving out natives, you know. It doesn't feel up. Yes, anyways, sorry, moving on.
Any other questions? All right, moving on. So what we know is we know that there are significant impacts that HR1 will have to our administration budget. It has significant changes to our Medicaid eligibility in terms of the eligibility based on immigration status, more frequent redeterminations for the new adult population, and the community engagement, or sometimes referred to as the work requirements for that particular population. DEVA is estimating that we'll need 12 new positions for the eligibility unit to meet the new requirements. And this will be reassigned from the population pool, which we're requesting about 510,000 general fund for that. There are also changes to our noticing that will be needed for the more required for printing more for the notices and being the ongoing mail, and that's expected to cost 290,000, which the general share is 72,000.
Leslie, and then I have a question.
Just for clarification, are you saying the 12 new positions are being reassigned from elsewhere? Did I hear you say?
From the population, from the state's position pool, yes.
Okay, so no new, but you're calling them new, but they're actually reassigned.
Yeah.
Thank you.
We have a proposal from various nonprofit organizations that do various outreach work with populations for several $1 million to help sort of become the navigators. And I'm wondering how you felt as though, I wonder if you feel as though they would enhance your ability to do this work, if they would impede. I'm looking for your feedback on whether that would be helpful for us to fund so that organizations that are working with individuals could serve as these sort of
Kind of
eligibility.
grants to community partners to do outreach. I'll let Addie.
I don't think they're even proposing outreach. I think they're proposing becoming able to work on eligibility to make sure things are all right. Go ahead, Laura.
Right, so I don't know if you've seen the proposal, but the organizations like the parent-child centers, I forget some of the other ones, but they're organizations that are already dealing with this population and that they could help facilitate ensuring that people know they need to do these requirements, helping them fill out paperwork, understanding that once they can't help actually sign them up for Medicaid, but can they help ensure that people are staying on Medicaid, which would then also help ensure that, we're getting the federal dollars from Medicaid.
Yeah, I would defer to Addie for that question.
Sure. Addie Strumlow, Deputy Commissioner. Thank you for the question. We actually have a meeting, I think, later today to go over that proposal. I don't think we've fully analyzed it yet, but upon first look, it appears to be something that's akin to our in-person assister program and attaching some dollars to individuals who get certified as assisters in community partner organizations. We are absolutely dependent on those assisters. They're a huge part of our eligibility program and providing application support in person. It's a huge part of this implementation and just our general work. So I think we'll need to get back to you on a position on that particular proposal. But if it's, leveraging what already exists and attaching some dollars to it, it definitely is worth looking at.
I have a question for you. Will we spend any time outside of the process diving into how they're going to handle these eligibility stuff? Or I could ask Addie now, what's the process? How are they going to make sure that they have the right process set up to ensure that they're reaching out to people and the forms and all of that stuff?
Is that something that we should do a little later when
That's what
they've
I'm
developed it a little bit?
I
Could you
do
do that possibly before the session ends? What do you
Yeah.
think?
I guess I just do have one question specific
Yeah.
to the form costs.
Yeah.
And this is coming from personal experience and working with the QHP. And there was a point where you all thought that my child was eligible for Medicaid, but she wasn't. But anyway, that led to getting a lot of forms. We would get 2 packets of forms in each day in my mailbox saying 2 different things. So, and we can do this offline, but I'd love to understand why there's an additional need for the notices and how that impacts what people are actually seeing in the mail. Is it causing more confusion? So we can do that offline, but I do want to dive into that for this 290. And then, sorry, one other question on you said you're taking the 12 new positions from other places. So why do we need more funding? Yeah.
I didn't get that, but that was my.
Tracy.
Yes, so some of the positions would be coming from our proposal at DMH to reduce 12 positions for the Vermont Psychiatric Care Hospital, because we want proposed to go from 25 to 21 beds. So you'll see it down in their budget, but then up in Steve's budget.
Okay. So is there a net increase, or is it net neutral?
So then I have a whole list.
Okay.
It's because there's also for DOC, for pretrial supervision, so maybe I should send a whole
Okay,
list.
that'd be great. Thank you.
May I briefly address the noticing question?
Yes.
I just
Oh,
wanted
sorry.
to clarify that this estimate here is solely for the newly required notices under HR 1. So I think I've been in the committee before to talk about this implementation. It represents a close to 30% increase in the overall eligibility transactions that we will have to process per year. And so on the noticing side, that estimate aligns with what the new notices that are required for additional redeterminations, work requirements, et cetera. Just wanted to clarify that.
Thank you.
Let's move on.
All right. Moving on.
Remind everyone, we have 10 minutes left.
Okay, moving very quickly. The school-based services will be moving to DIVA, as the secretary mentioned earlier in her testimony. This is the AOA will retain the responsibility for alignment with the policy. And so with that, DIVA is requesting, has one new position for the DIVA business office. There is the electronic health record and the random moment study systems, which will be implemented in October. And those setup costs will be covered by a grant, but however, will need ongoing maintenance support beyond that. And then the DIVA will also be taking over the payments to the school districts in that transfer.
Is AOE have a reduction in staff
I'm not,
coincide with the new position at DIVA?
I don't know, but Ashley Berliner has been the one who has been tackling the school base, and she can come in and.
All right. And we're gonna take some testimony on this also.
Yeah, letting your open out.
Yeah.
Well, that's what you.
So turning to our program budget, for baseline changes, the caseload and utilization, we're seeing an up of 14.93 of the general fund. What we're seeing is while HR1 has played a significant role in the caseload calculation this year, especially for the new adult and general adult eligibility groups, there's also a increase in the general adult PMPM spend from FY25, which needed to be reflected in the new PM. So while we're seeing a decrease in the caseload, the PMPM is higher and does not offset that kind of decline in that. The other thing here is the Medicare buy-in. This is increasing because of the caseload forecast and an annualized rate increase from the feds that it's causing that.
Wait, which line are you on? Are you talking about the increased RX prescription?
No, I'm not there yet.
Oh, you're not there?
I'm not there. Do you want me to jump?
Okay.
I'm just at
No,
line 2.
you're just on line 2, okay?
For the Medicare callback, that is the Medicare prescription drug payment. That's the callback we have to give to the feds. It's a result of associated costs there. We generally try to absorb that callback cost, but this year it's just too much that we have to. There is no offset. The annualization of the Medicare savings plan expansion, that amounts to the 7-month expansion for the Medicare savings program, which we expanded that to 150% of the federal level. The FQHCs and RHCs are a required rate increase.
I'm sorry, I'm confused because your slides are like,
They're not
referring to anything you're talking about. I think you might have missed a slide.
Yeah, you could go back a slide. I apologize.
Yeah, I was.
Thank you, because I was like, that is very really adding it. I hope it's not me.
Well, I'm looking at the slides and there is no slide for these.
You don't know what happened.
Are you talking
Perhaps
about the
it slid out.
HR1 impacts the DIVA admin budget?
Are you on the DIVA?
That's slide 9.
I'm in the book.
You're in the book now.
Okay, so.
That will start on page.
Oh,
49.
You have nothing in your slides on trend and baseline changes.
There should be a slide. There was a slide yesterday.
Okay.
I think there was a slide yesterday. Yeah.
Oh, and it happens to be $56 million, so you're missing the slide on that. Okay, so you clearly don't have a slide on it, so if you could just talk us through it a little bit slower.
I will go slower since you
Okay.
do not have the slide and I do. Okay, so with the, and I gave you my.
Oh, here.
Oh, no. Sorry.
No.
I did not realize I was going to need this today. So part of that slide is the consensus for the caseload and utilization. That is not the correct number in the budget book, but the slide should say, if you had the slides, it would be 14.93 of the general fund, 35.48 of the gross. And so a part of that increase is that while we were seeing that decrease in eligibility for the new adult and general adult population, the PM for the general adults was increasing. And so we are seeing it because there have been increases in the PM, it's not offsetting the decrease in the caseload.
Do we know why utilization is increasing? I mean, we've got MDWAS now, so we should know, shouldn't we?
We have not looked into the utilization of what are the cost drivers of that.
Okay. Okay.
Okay. The next one is the Medicare buy-in program. So this is the federal.
We got the slide back.
Okay.
Thank you.
Okay, the buy-in.
Okay.
Yes.
About this caseload, I do want to say that the caseload utilization, that is JFO has bought into it. It does, the trends are first of all, these are projections.
Mhm.
So we can't talk to why that's happening. But I want to just sort of highlight that JFO agrees with the consensus and based on the trends.
Oh, absolutely. I don't dispute the
Yeah.
consensus that it is. I'm just wondering if we're looking at why.
So I think I was at the Medicare buy-in. That's the federal government allows the states to use Medicaid dollars to buy into for the dual eligibles for Medicare. The caseload sees gradual increases. This year, we're basing this on the caseload forecast and the annualized rate increase from that. So that'll be 0.7 of the general fund. The third line is the Medicare Part D clawback. That is the Medicare prescription drug, the Part D portion of which we have to do that to the feds for the prescription drugs. This reduced state, so it requires us to reduce them, and this is the associated cost of paying them the feds back. The third and the other line is the annualization of the Medicare savings plan. So this is what it's cost for the 7 months to expand that program there. There is the requirement of the FQHC and RHC rate requirement that is a 2.7 adjustment for 27. I'm just making sure the slide is fine. Then finally, there is the applied behavioral health coding correction, which I know we'll dive into that at 2 o'clock.
I think tomorrow, maybe?
That was today.
Oh, is it today? ABA. Okay, so we're diving into that later. So
I'll briefly go over that, and that's part of the cost savings. And then lastly, the family planning rate. DEVA was unable to implement the appropriated rate increase with the legislative intent of drawing down that enhanced match.
is there in the language section of the budget, is there suggested language to make it implementable?
There is not language session, but there are discussions on how to make that. So we're still having discussions on what is needed. If the committee is thinking of moving this forward.
Okay. Go ahead.
Can you remind us of family planning rate, what that is about?
Last year, there was an appropriation to DEVA for 85,000 in general fund with the intent that the 90-10 match that is available for family planning services would allow that to be grossed up to $850,000 worth of increased rates on family planning services.
What are that? That's what I don't remember.
Well, that is part of the challenge in implementing anything. There is currently, for the way that Medicaid has operationalized its official 90-10 match eligible family planning benefit, a list of procedure codes and a list of diagnosis codes. When provided by certain providers, the claim will trigger a 90-10 match rate. I apologize, I'm going to get really technical.
It's okay.
The challenge that we have is the different codes that are on that list live across a variety of our different fee schedules, and all different providers can bill those codes. It's not just providers of family planning services. So for example, there could be something like an evaluation and management code, sort of general code for an encounter with a provider. It becomes a family planning service when it's done by a certain type of provider for a certain diagnosis that a member has. But when that same service is done by any other provider, it is not a family planning service. And so we cannot force the dollars into the 90-10 match construct. And so we have to have more conversations about what is possible within our system in order to make sure that we are targeting dollars to what we would consider family planning services, while not also creating a pretty significant upward pressure on the budget for the same services when not done in a family planning context, meaning for a specific diagnosis or by other providers.
May I ask, first of all, how long has this 90-10 match been in existence?
I believe we have had that option for several years. I would need to look specifically.
If I said close to 20, would that be accurate?
I don't know. I will have to.
Okay.
I'm still,
And
sorry.
this is administered by Gainwell. The system is Gainwell. Does Gainwell have contracts with other states? With other, I mean, they're a national claims processing contractor. Do they do this for anyone else?
Our national contractor, each state has its own version of a Gainwell product. And our particular Gainwell product is about 40 years old. So other states have newer products that are, say, more nimble than ours is. And so making changes does take a little bit more effort to make sure that the resulting process is aligned with the intent.
Okay. I would hope that you could implement this as intended, as our intention, legislative intent. It's been a while and this isn't the biggest problem in the world to solve. Let's move on. Sorry.
Next slide. It's coming. Okay. There's one rate increase for the Northern Eastern Family Institute for the hospital diversion program. This rate increase is targeted towards that one specific youth hospital diversion. It had a required rate review, and thus an increase is as a result of that. This is something that came out of our joint conversations as part of the executive leadership team. The next set of items are kind of policy changes for the budget reduction. There is the per diem of the emerging department stays. We are recommending discontinuing this per diem amount for mental health extended stays in the emergency department. This starting in July 1st. This rate was first implemented in July of 2022 as a temporary crisis response, and the utilization has since declined significantly. We have also had the Clinical Utilization Review Board weigh in on this policy, and they have also kind of they recommended discontinuing this due to this minimum uptake, and this should have little to no impact on the hospital providers. The next one is the discontinuation of the dental incentive payment. We recommend eliminating these payments. These were intended to encourage private dental provider practices to accept Medicaid patients. However, with the modest payment amounts have not resulted in measurable increases to access for Medicaid, for dental access. And given that limited impact, we're recommending that the payments are no longer effective.
Incentive payments, are these on top of the increased reimbursements that we did a few years ago?
These are on top of any sort of like dental payment that we have. So yeah, so this is an addition to.
It would be nice if we could get it says, I mean, you have that it has not resulted in measurable increases. It would be nice to know if we could know what the increases have been and how de minimis, I guess, that they have been.
You consider the
yeah.
correction, the last technical correction bill.
Yeah, I just, I feel like I realize that all the departments came together and worked collaboratively on this within AHS and that hard choices were made. I know hard choices were made, but I think as we sit here trying to make good decisions, we need the same information that you had when you made those decisions. And so if we could flesh out some of the data and the reasoning behind why certain programs were eliminated or decreased, that would be really helpful to us as we move forward making decisions. Go ahead, I'm sorry.
I will say, I mean, I think this will be hard to kind of look at because of there's kind of, we're looking at a whole system of changes that may have influenced why dentists have or have not participated. So I think we'll need to kind of think about how to present that data back to you. The last one is, or not the last one, we are recommending an increase to the prescription copays for preferred, $4 for preferred and $8 for non-preferred. The current copays are $1 and $3, which have been in place for many years without any change there.
Why are we doing that?
It was kind of the executive leadership came together and we had to make hard choices of how to lessen the budget shortfall. This is one of the things that we have ran by that DEVA has contributed to as a proposal that we've asked our pharmacists to weigh in on. And this is one of the things that they had recommended.
Is the amount that people pay in copays, is that also, I don't know how we describe it, that we have to basically share with the federal government, just like because premiums for VHAP that people pay doesn't a certain portion of that have to go to the federal government? Yes, no? Oh.
I'm not sure, but
Are copays also included in that?
I'm not sure. We can get back to you.
So we're cutting people's benefits. And when I say cutting their benefits, we're increasing their cost sharing to save the general fund a little bit of money. And in the meantime, we're sending the federal government more money.
I would have to, let me get back to you on whether we send money back to the feds on copays.
Is there a rationale for 4 and 8?
That's, I think,
Inflationary thing in there?
there is a rationale for that, and I cannot remember what the reason was, but I can get that to you when I answer the copays.
Okay.
I will also say that there is a 5% copay cap, so beneficiaries cannot go over that copay cap. And so that's kind of also, so that's something else that we have there. The next item is utilization management. This is the Diva Clinical Unit has been engaged in several kind of initiatives related to efficiency and system alignment, looking at clinical best practices in areas of DME, so durable medical equipment, looking at special rate agreements, coding reviews, and other items. The estimate that you see is based on a reduction of 0.25% in the acuity adjustment that is applied to the consensus process for this intended outcome.
Yes, go ahead, please.
Recommend this, but we just got some clarification about the co-pays.
Yes.
Apparently, we don't actually have co-pays anymore. We only have co-pays. No, so we don't collect premiums anymore, only for B farm.
Oh, well, that's what I,
Yeah,
Only the what?
only for B farm.
yes.
Sorry, farm company.
And we have to share what we collect in premiums.
Yeah, I believe so. It used to be.
And I'm wondering if we also have to share what's collected in co-pays.
Yeah. I will find out.
Okay.
Sorry.
And then the last one is the base funding reduction, and that is the 4.7 PMPM that was for the ACO. And because we no longer have the ACO, that sunsetted at the end of last year, we're asking to reduce our base funding by 2.01 million. Alicia, do you any questions there?
Is this to the hospital global? Your narrative seems to be referring to hospital global budgets. Is that what this is? Because the slide from AHS kind of indicated that it was elsewhere.
Is not elsewhere, which is why it represents a reduction to the base funding.
I think what the narrative may be saying is that while we are getting rid of the PMPM payment, there is still a population-based model in the hospital global budget that it will still continue.
Okay. Would really like to know who this is going to, or now no longer going to, I should say.
The $4.75 per member per month went through the ACO and was distributed according to their contracts with participating providers. I believe across the system, it was primarily going to primary care providers, but also some of the funds were available to other community providers as well as part of the broader population health model that OneCare had. In terms of specifically the 75 and how it split across those providers, I'm not sure. That's something we would have to talk to OneCare about.
Okay, so I just want to be clear, this is not Blueprint. It's not the Medicare blueprint. It's not the Medicaid blueprint. It's that Medicaid management fee that has been around forever and ever, that was $4.75, that then when the ACO came into existence, it was being paid out through the ACO. Is that the one that we're talking about? There's so many per member per month things to keep track of. I'm trying to figure out which one it is.
Yes, I think there was something that had existed before our ACO contract that was discontinued. For the last several years, we have had the $4.75 per member per month going to the ACO, and they have fully distributed that to providers according to their own contracts.
Okay. But just so we're clear, this base funding reduction is a cut to primary care. Okay, moving on.
$2 million cut.
5 million gross.
I don't have my glasses on, I'm sorry.
Yes.
Out of the general fund, which
Mhm.
leaves $3 million federal dollars on the table. Okay. Thank you.
Okay, next.
The next slide is just one-time funding for HR1. These are system changes that need to be in place. The expected range is to be 5 million, but about 2 million is we're able to be awarded through the HR1 fund from the feds to offset these costs. We're expecting that the remaining costs be matched at 90%. The estimate will be refined and updated over the next. There's also a specific outreach activity that will also need to be funded, and we're hoping that the 340,000 gross costs can be covered by the HR1 grant from the feds. But we're waiting for CMS determination to see if those costs would be covered.
When we talk about system changes, what are we talking about? Like physically, like IT systems, or are we talking about just how we change doing business?
Mostly IT systems. Addie, do you want to give? I see her.
Sure. Yeah, so this gets at testimony I gave earlier this session around the HR1 eligibility implementation. We have 3 kind of major work streams that have to be implemented during 2026, and they all have a direct impact on our eligibility system itself. So it's functional IT changes that need to happen this year.
Okay. All right.
And then the last one-time requested funding is for the provider stabilization for the $2 million to assist in supporting providers. And we did a report on the stabilization funds that we saw that come in this year. And that's the link on the slide.
So last year, I think we put 10 million in,
Correct.
to which it was promptly asked for, and most of it distributed. And last I knew, you still had several grant applications pending.
Yeah.
And we think with all the changes that are coming in the next year, that 2 million is going to be enough to hold in a provider stabilization grant fund.
This is what has been put into as the proposed government recommendation. So yeah.
I think I have a question.
Yes.
So how does this impact, this H1 required certificates impact low-income Vermonters? I'm not sure that you can answer. No, I think I'm not getting it right. I'll come back.
All right, we need to get moving on, and maybe if questions come up, we might have time this afternoon because you're coming back in, and we could ask at that time when we finish up that testimony. Thank you, Commissioner. Thank you, everyone. All right. We are moving on to Green Mountain Care Board. Are they in the room or outside? Oh, they're all on Zoom. Oh. Hi, Kate. Hi, Michelle. Hi. Good to see you both. So we received a report back, what was it? January 15th, I think.
Yes.
And this was legislation that we did 2 years ago, I think. And I thought that it would be a good time to get an overview of our first report on this.
Yes.
So really
thank
excited
you.
to have you.
Yeah, thank you for the opportunity. I'm Catherine O'Neill, Director of Prescription Drug Pricing at the Green Mountain Care Board. And I have with me today Michelle Luengas-Lozano, who is a health policy analyst on our team. And we also have with us today Jane Horvath, who is one of the contractors that we contracted with, who is our policy expert and is available here to answer questions when we get to that part. We have I'm going to say about a 15-minute presentation for you, if that's okay. I know that you're a little behind schedule, but we should be able to get it all in if that's all right with you.
Yes, thank you. And we apologize for that.
Oh, no worries. No worries at all. So I think you can see, I just switched the screen to Act 134 of 2024. So, yeah, so just really quickly to start from the beginning, Act 134 passed in the 2024 session, and it directed the Green Mountain Care Board to explore and create a framework and a methodology for implementing a program to regulate prescription drug costs in Vermont. We were directed to research promising federal and state strategies for lowering prescription drug costs, also to look at the board's existing authorities and impacts on Vermonters' access to medication, as well as cost impacts across Vermont sectors. So, quick overview. In December of 2024, we executed an analytic contract with OnPoint Health Data, along with Horvath Health Policy, to help us conduct an in-depth analysis and a national landscape review to develop evidence-based policy recommendations, which we're here to talk about today, and for those recommendations to look at addressing drug spending in Vermont. So the policy recommendations, reports, and data dashboards, they're all the result of this one-year-long collaboration. So I've linked here for you the 3 reports that we produced. There was a preliminary report that was due. We did an interim report in May of 2025, and then we just submitted to you the final report in January of 2026. These reports describe current activities and initiatives in states across the U.S., as well as at the up at the federal level, and offer evidence-based project options for your consideration. We also produced 3 data dashboards. These are links to those data dashboards. You can link to them right from the Green Mountain Care Board website. And there's a lot of great stuff in there, so I encourage you to do so. These dashboards illustrate potential cost savings as well as analysis of trends in spending and utilization of prescription drugs in Vermont. And when I'm done, Michelle's going to walk through just high level, briefly, some of that analysis. Also, through this past year, I want to remind you all that the Green Mountain Care Board did implement some regulatory levers. Act 55 of 2025 restricts Vermont hospitals, except those designated as independent critical access hospitals, but all of the rest, from billing insurers more than 120% of a drug's average sales price for drugs that are administered in the facility. And that restriction, those caps are underway in the hospitals now. Act 55 also requires Vermont hospitals that participate in the 340B drug pricing program to report on their participation. That's happening right now as well. So in considering new opportunities for reducing the cost burden of prescription drugs in Vermont, we took into consideration that Vermont's small population and the limited legal authority of a state to directly regulate drug prices, it favors what we're going to share with you today, cost containment strategies that are voluntary and market-based. So this means that success would depend on broad participation from in-state stakeholders, purchasers, providers, pharmacies, employers, health plans, consumers, etc. So what do we mean by this? Well, this slide just gives you a brief summary of the policy recommendations that we outline in a little bit more detail in our final report to you. But in summary, we've got 5 key policy recommendations. The first is that Vermont should consider implementing alternative purchasing models through 2 organizations, Civica RX and Cost Plus Drug Company. We'll talk a little bit more about what we mean by that in just a minute. I'll just do this summary first. And so also, we think that Vermont needs to continue to monitor the activity and the success of prescription drug affordability boards that are in place in other states, not to implement one today, but to watch for the impact that those boards are having, as well as the cost effectiveness of the activities in those other states. So it's still a possible opportunity for Vermont, but we're not recommending today to establish a prescription drug affordability board. Third, we recommend distribution of a new drug discount card. I know that you're already looking at this in the Array RX program opportunity. Why we make that a recommendation is because Vermonters use discount cards now. And the organization Array RX, which I know you're learning a lot more about, we just think, it's a better program, or it's a better organization because it has better privacy and data privacy and consumer protections, as well as there's a slightly better reimbursement rate, which might be a little bit more palatable for our local pharmacies to consider. So in general, though, the use of discount cards is definitely a recommendation that we would make. We recommend the establishment of a new advisory committee a new advisory committee which would kind of attach to the first recommendation around a new purchasing model system, because we know that it's very important that all of the elements of the pharmaceutical supply chain and the experts in Vermont in those areas need to be a part of that process. And finally, the last recommendation is around establishing a robust price transparency program. That, of course, isn't a policy solution itself, but transparency supports policy solutions. And so we do recommend that. We're going to focus right now here today on that first recommendation, establishing an alternative payment model for Vermont. I'm going to turn this over to Michelle so she can walk through some of the data and what led us to this recommendation. But just briefly, I want to share that the analysis that we did this year was done with support of our analytic contractor, OnPoint Health Data, which conducted the analysis and developed the dashboards that you can take a look at. They're available on our website and linked on our slide. They used VCures for the analysis. They imputed data that's missing from the self-insured plans, because not all self-insured plans are required to report into VCures, and they applied inflation factors. But an important note that I want you to keep in mind is that VCures does not have rebate data. So projected savings that you're going to see is based on the allowed amount prior to any application of any rebates. So now I'm just going to let Michelle walk through some of the data, and then I'll come back and wrap it up.
Good morning, everyone, and thank you, Kate. We'll now turn to recent trends in Vermont's prescription drug spending between 2018 to 2023, just to help contextualize a bit the scope of this challenge in the state. All right, so this chart here shows how prescription drug spending in Vermont has grown across all payers since 2018, with retail pharmacy spending reaching nearly $1.2 billion in 2023. It's important to note that we're now in 2026, so in all likelihood of cases, we have surely surpassed this point. Medicare represents the largest and fastest growing share at nearly $5,000 per member per year spending in 2023. But spending is rising across commercial and Medicaid as well, statewide. And analyzing VCure's data, we see that there is a disconnect between what we use and what we spend. The chart on the left shows us that across all payers, generics make up an average of 82% of all prescriptions filled. But as seen on the right, it is brand name drugs that account for nearly 86% of total spending. This is especially clear in Medicaid, where a relatively small share of brand prescription drives a large share of cost. In short, spending growth is being driven by prices, not prescription volume. Next, we'll take a closer look at Vermont's top 25 prescription drugs, focusing on worst spending utilization and cost growth are most concentrated between the years of 2018 to 2024. All right, so first looking at total spending in 2024, it's no surprise that again, the costs are highly concentrated in brand name drugs. Humira alone accounted for nearly $80 million in spending, followed by Eliquis at about 58 million and Ozempic at roughly 47 million. Biologics such as Enbrel and Skyrizi ranked highly as well, reflecting the high cost of treating chronic inflammatory conditions. Measured in a 30-day supply of the prescription, utilization across all payers was largely driven by generic drugs. The most widely used medications were cardiovascular therapies, such as atorvastatin, calcium, and lisinopril. Mental health medications also ranked prominently with high volumes for sertraline, bupropion, and more. It's important to note that these mental health medications are just a little bit more highly filled among Medicaid members as well. Next slide. Finally, looking at price growth over time, the largest increases occurred among certain brand name drugs between 2021 and 2024 when looking at 30-day price equivalents. Kisqali increased by about 140% in price, and Hemlibra by roughly 129% in price, despite very low utilization among both of these. Other drugs across immunology and mental health also saw increases of 20 to 50%, showing how price growth rather than volume can still have a significant cost impact. So because generics make up most prescriptions in Vermont, we'll start by looking at opportunities to lower generic drug prices. In doing just that, we analyzed how a cost plus pricing model compares to current Vermont spending for commonly used generic drugs and where it could reduce costs across payers. Okay, so the first, the cost plus drug model would be a voluntary cost control approach that uses transparent pricing. Specifically, it would be a manufacturing cost plus a 15% margin. In practice, Vermont could leverage this model through a rate-setting reimbursement approach. Public and private health plans would reimburse at the cost plus price for a defined set of generic drugs, and provider networks could be limited to pharmacies willing to stock those drugs and bill at the cost plus rates. This creates a consistent statewide pricing signal while allowing participation to remain voluntary. Based on current utilization, 1,811 generic drugs are already used by Vermonters in the state, and they could be covered under this model. In 2023, retail pharmacy spending on these drugs was about 32.9 million across all payers, with the largest share in Medicare. If this were to be adjusted for inflation, that spending is projected to have roughly been 36.4 million this past year in 2025.
A couple of questions, Michelle. Go ahead, Leslie.
This is just a clarifying question. On your third bullet, it says it would cover about 1,800 drugs. You know what the denominator is?
Oh, I do not know. That would depend on the list of drugs that are found under Cost Plus website. We can gather that for you. Our subcontractor would know that for sure, but we just don't have that on hand.
Yeah, it would just be, is it 10% or 90%? Just curious.
Oh, actually, that reminds me, when I looked at a past statistic, in 2023, it accounted for approximately, I believe, 19.4% of all medications used, generic medications used by Vermonters.
So it covers about 20%, about 20% is what you're saying? Exactly. Model? Thank you.
So what you're using the cost plus model, but you're not suggesting using cost plus. You're saying that Vermont could sort of start its own cost plus and for generic drugs.
That's a good
would this bypass like the PBM?
Jane, I'm not sure if you want to try to answer this one.
Sure. So Cost Plus has expanded into different parts of the pharmaceutical market. They are a generic manufacturing company and a public benefit company. They are also a wholesaler now of their products. So it would be buying from Cost Plus through their wholesaler, basically. And that the wholesaler can then get the product at that price into the state of Vermont. And it wouldn't bypass PBMs, but it would, the whole thing works around that the Cost Plus is typically the lowest cost product in the market, and that is their goal. So to the extent when it comes in, the price is transparent. So the pharmacy would bill based on that, the health plan or the PBM would pay based on that Cost Plus. So there's no rebates going on. It is what you get. Like, it's just straight up pricing.
All right, thank you.
Building on that, the slide shows the potential savings if those same drugs, so the 1,811 that we just mentioned, were priced under a Cost Plus model in 2025. Across all payers, estimated annual savings would total 23.6 million, representing an average 65% reduction in spending on the Cost Plus list. Medicare accounts for the largest share of savings, which would be approximately 14.1 million, followed by commercial and Medicaid plans. These estimates reflect pricing changes only and assume no change in utilization.
May I ask, when you keep referring to Medicare and then Medicaid, are you including in for dual eligibles, are you who get their prescription coverage through Medicaid, are you including that total in the Medicare dollars or the Medicaid dollars?
I think that would be more a question for our subcontractor, if we're completely honest. But Kate, do you have any
Yeah,
input?
I don't know that, Chair Black, for sure, but that is a question that we can ask them. It's gonna, I think the answer would be they are accounted for in one bucket or another, but I would have to ask them or look into the detailed methodology.
Okay, thank you. That would be great.
Next, I'll turn to Civica RX. It's another market-based approach that focuses on lowering the cost of essential generic drugs, particularly in hospital settings. So Civica RX is another market disruptor in the generic drug space. It offers transparent, cost-based pricing and focuses on producing generic medications that are commonly used in hospital and patient care, where shortages and price volatility can be easily disruptive. Civica has its own manufacturing and distribution infrastructure, which allows it to supply hospitals with essential drugs at consistently low and predictable prices. And I think I would just go ahead and maybe you would have the same question that you had for Cost Plus. In this scenario, we would also be contracting directly with Civica RX. It's really just purchasing their generic medications for inpatient hospital setting. And next slide, Kate. So in Vermont, participation in Civica RX would be voluntary and primarily focus on inpatient hospitals. The state could support participation by facilitating Civica RX membership for these facilities to encourage use of Civica's lower cost products, such as its generic insulin. Health plans and PBMs could align reimbursement with Civica's published prices. This approach would complement the Cost Plus drug model by targeting a different part of the drug supply chain, particularly inpatient and hospital administered drugs.
So I understand, I mean, so essentially if we're talking about inpatient prescription, inpatient pharmaceuticals, does this assume that the hospital, which would be billing as part of their inpatient, that their prices would reflect what their acquisition cost? I mean, because ultimately the hospital is the one that's getting paid and billing for it from the insurance. Is, I guess what I'm saying is that would this be reflected then in their prices?
Do you want me to speak to that?
You can take a stab at it.
Yeah, so the hospitals bill pretty much on a global basis based on whatever the patient is in for. So it's a bundled payment. So,
Okay,
and these are all generic products. These are, for Civica, they were started by a bunch of hospital systems and a couple foundations to really deal with the issue of inpatient generic products that go into shortage a lot, but they are critical to inpatient care, like saline solutions and things like that. So it was to stabilize the market and stabilize the pricing and the access. So hospitals would presumably get through Civica, because to the best of our knowledge, Vermont hospitals do not participate in Civica, and they could, and save money on their inpatient side. These are, again, generics, and it is a bundled billing and a bundled payment. So the generic drugs wouldn't necessarily be pulled out, but it would help lower their costs, or at least help minimize any cost increases that happen in the sector. Because again, these are a lot of generic products. But importantly, with the Civica, they have stretched their business model into outpatient insulin. So, and they now have outpatient insulins on the market that, again, they have their wholesaler, and it could come into the state, into the pharmacies and other places where people purchase their insulin. And again, it would be a very transparent price. It would be a low price. Pharmacies would bill based on that Civica price for the insulin. It's part of the deal. If you get the Civica insulin, you must sort of abide by their pricing constraints, which is you can only have so much of a markup if you use their insulins. So pharmacies would bill based on that, and insurers would reimburse pharmacies based on that. And it would lower the cost for consumers, just as Cost Plus would lower the cost for consumers at the point of service.
okay. Thank you. I think that, and hopefully it would lower the cost of the bundled payment, which one could only hope. Thank you.
Okay, so thank you, Michelle. I'm just going to bring it home for us all. So what we just described here is, we've said a couple times now, they're voluntary programs, and it means if adopted in Vermont, health plans would agree to reimburse at the Cost Plus and Civica prices. We don't think that there should be any administrative burden for plans to, say, track participation. We do see alignment of financial incentives across the marketplace with this model. And as Jane said, and I'll just say again, what we like about this is pricing is transparent. And so I will point out, though, that, in our thinking through this, in the event that pharmacies would see reduced margins, we want to recognize that plans could consider adjustment to compensate for that. And there is a potential for 340B profits to be a little bit reduced, but it wouldn't eliminate the profits entirely. So there is that to, think about as a consideration. Is that a question for me? I'm sorry, I didn't.
No, I think we were clarifying. We're fine.
Yeah, thank you.
So just real quick, aligning stakeholders around Cost Plus and Civica participation. We think it could provide Vermont with a pragmatic, scalable process to reduce prescription drug spending without reducing or, certainly maintaining access. We know that this approach has to be multidisciplinary, and it in of itself is, could be effective in bringing down the cost of generic drugs. the real big spend is in brand name drugs. And so, this is a complement to any other potential opportunities that there may be in addressing expensive brand drug costs. So to that end, super quick, unlike the generic market, the path for Vermont is less clear for brand name drugs. We do want to continue to monitor the various approaches that we see developing and changing in the marketplace across the U.S. And an example of some of those approaches are here on your slide. And I do want to just touch really briefly on the maximum fair price analysis that we did, because in Act 134, the statute specifically asked us to investigate the impact and any opportunity for expansion of CMS's maximum fair price drug price negotiation program. So we did conduct a repricing analysis to look at what the savings could be, and if we were to be able to negotiate prices or use the negotiated prices expanded into the commercial and Medicaid market, we can see that there is a potential for dramatic savings. And the yellow bars on this chart illustrate some of those savings for the highest spending drugs.
Could you remind us what the maximum fair price is?
It's a federal program out of CMS where they negotiate with drug manufacturers lower prices on certain drugs. And 2024, they negotiated down the cost of 10 drugs, and then in 2025, I think it was 15. I think they just announced another set of reductions, and so it's the amount that the Medicare program will pay for these brand, this certain set of brand name drugs. So what would it look like? And we in other states are looking at, what would it look like if we were able to expand that to, reduce the amount that we would pay for drugs in the Medicaid and in the commercial market. Okay. I'm going to stop there and let Jane jump in.
Thank you. I just wanted to say the Medicare program with these negotiated prices just started January 1 of 2026. So it is like brand new in the market. And it is pretty complicated. So a state sort of overlay on this administrative system that CMS has set up between manufacturers and pharmacies and payers would have to slip in there. And it's just not clear yet how that would work, which is sort of why we don't have a recommendation. There's 6 weeks under our belts, I guess, of this program, and it's a pretty major program.
So this is sort of an aspirational, if we could, okay.
Yeah, it was. I think a useful exercise to look at what an expansion within Vermont would look like in the Medicaid and commercial market. But it is at this point a theoretical exercise because there are, as Jane said, there are challenges to program expansion, but not least of which are recent federal law changes that permanently exempt a number of drugs from negotiation. And it's a big deal. It's orphan drugs are very, very expensive, and there's a lot of complicating factors in there, and the new law it really limits exempts them from negotiation, so it limits some of the highest price brand drugs from even the ability to be negotiated. We can talk a little bit more about that, but I won't right now. But I do want to say that drug manufacturers are starting to provide price concessions voluntarily, and we're seeing that. And direct to consumer efforts are expanding. And so as Jane said, this is the Medicare Fair Price Program. The negotiated prices have happened over the course of a year and a half, say, but the actual implementation of these payments, these pricing structures just started. And so the savings through the MFP program might not be as dramatic over time. So it might not be as exciting to look to expand it. In other words, there's just a lot that's changing in the marketplace that means let's watch, but we need to see how these changes impact the potential for savings.
I think Leslie had it. Leslie, did you have a question?
I do. On slide 25, you talk about the big picture, which is interesting to me, and you were talking about aligning stakeholders. And
Yeah.
I'm wondering who you see leading this conversation.
Yeah, that's a great question. I love it. I would love to see my position and Michelle's position be, able to continue in this space to move us forward. And I think that that just, it brings up a question of, where Vermont wants to go, what we want to, what are our priorities around this, and where do we see this work going forward? I think that the Green Mountain Care Board does have the capacity to establish an advisory committee. It has done so in the past. This would be new and different. If there is a collective interest in this, and know that, over the course of the fall, as we were framing this and standing it up, we did meet with stakeholders to understand, to like kind of vet this a little bit. And it's all brand new. So there's interest, there's intrigue, there's curiosity, there's some concern. And I think that, one of the next steps is to, if we're going to do something like this, is to bring stakeholders together, with an intent to, try to solve this problem, to move forward with a program like this and address the issues for Vermont. Michelle?
Yeah, go ahead.
Just so
I'm sorry, I couldn't.
go ahead. Sorry.
Yeah. Oh, sorry. I was going to, no, don't worry. I was just going to quickly add to Kate's point is that, for example, if we were to try to work with Cost Plus, this doesn't mean that the 1,811 drugs would be all covered. We would actually need a group of stakeholders to come together to form a list of medications that we would want to get covered. And this was seen, I believe it was the University of Pennsylvania Medicine that they contracted with Cost Plus, and they made this list together, but it wasn't just them two, right? Like, for example, we know that Kate and I know it's possible to get a group of stakeholders together because that's what we've been doing these past few months and making and preparing for this presentation. And this would include interest groups such as pharmacists, people from insurers, payers, Blue Cross Blue Shields, and really experts like Jane here as well. We know it's possible, and we know it can be scary, I think, for other people having such a new program. So we do need their expertise to help develop it, but it's also to be as transparent and focus on communication between everyone involved, so there's no lingering questions if a program like this were to move forward.
Can I expand on that? Sure. Would you need any sort of legislative in?
Who leads it? Like, you can set up an advisory committee without statute? Or do you need?
To align stakeholders, you don't need our permission.
Right.
Well, so that's right. But we need, I think for us to move forward, it would be important to know that there's collective interest in doing so. And so I don't know if statute is needed. We didn't write legislative language into this because it doesn't necessarily have to come out of statute, but we need authority to do this work. Our positions are at the Green Mountain Care Board, and if it's a priority of the Green Mountain Care Board, if it's a priority of the legislature to assign this work to the Green Mountain Care Board. You know, we've gotten our two positions were written into Act 134 to get us this far, to get us to the point of making recommendations. If these are palatable recommendations of interest, then you know, we do need to have a conversation about the next steps. Where does this fit? How does this fit within the priorities of the state? You know, is this work best done at the Green Mountain Care Board, or is this work best done in another agency, perhaps? Our positions exist, and they exist at the Green Mountain Care Board, I think, for a reason to get us started here. And so moving forward, I do think conversation needs to happen. I don't know if it necessarily needs to be in legislation, but Michelle and I do need direction, like as staff.
Okay. I was just wondering if you're limited, are you and Michelle limited service positions?
Our positions are not limited service positions.
Okay.
And there is a funding source that funds this work through, I think it's out of AHS. The Joint Fiscal Office knows a lot about this, but it's the Evidence-Based Advertising and Education Fund, which is actually a manufacturer's fee that, you know, I'd love to have more conversation about that fund and how we collect the fees and ensuring, you know, adequate collection of those fees and the, you know, the quality of that. And how the funds are used. But I know that, you know, so yes, we're permanent funded positions, and we have an allocated, dedicated funding source.
So I'm just wondering, can we expect to hear from the Green Mountain Care Board, your report? Yeah, I'm looking at Diane because she's across the room from me as opposed to your little box. Because I just don't want it to be on the shelf, right? So where does this go, and who's leading the next steps?
I think we'll have a conversation regarding
with
we'll probably start with Diane.
Thank you. That's all I wanted to know.
Thank you.
Chair Black, may I ask a question of the committee?
Sure, of course.
What do you think?
Great question.
I have to tell you that I think I got really excited. I read your report when it came in, but I think I sort of got excited when we had Charlie Becker from the Healthcare Advocates Office when he was doing his presentation on Array RX. And I don't think I'd really quite understood the cost plus model. And so I was really excited about that. Additionally, I've been, well, I'm done. Forget it. I went to a conference on prescription drug affordability this past fall, which has gotten me really thinking around, you know, our whole supply chain and how we, the whole market, like the pricing, the manufacturer's pricing and what's involved in that, and the coverage and the difference between the US and the rest of the world. And it was just, so yeah, I was excited for your report because I've been thinking about it a lot, and I really like sort of this model. Anyone else? What does the rest of the committee think?
I don't want to know.
As of right now.
I didn't hear, I'm sorry.
It just sounds great as of right now.
Yeah. Alan, what was your?
I think we're going to need the whole thing of RX cards before we go to the hospital or the pharmacy. How will that, I know it says hospital, but it's got to have some impact on Array RX if we continue with that. It's got to have.
Yeah, but
So how do you do
We're
it?
just looking for, well, we wouldn't
Short-term and
do
long,
this.
short-term and long-term.
Short-term and long-term.
They are
The thing that I like about both of these is the transparency. You know, I mean, at the market that we live in right now, nobody knows what they're paying, why they're paying what they're paying. There's no transparency in it. And it's so multi-layered and so interconnected and vertically integrated. And, you know, I like just the transparency of it.
I'm for all this, except it's going to be very confusing to a lot of citizens.
I don't think citizens would actually know that this is happening behind the scenes.
It's back.
Hopefully not.
Yeah.
I think that's, Jane, go ahead.
So that's a really good question about the discount card, the Array RX card.
Yeah.
So what this is all about is procurement and supply chain. And so the Array RX can work with the supply chain, basically. Array RX is like a payment mechanism. The pharmacy agrees to charge only so much for these products. The discount card benefits pharmacy because it sort of drives some volume to the pharmacy and things like that. So Array RX it can work, and I don't think it'll be confusing. It can be overlaid on top again, because this is the product coming into the state via Civica and their wholesaler, and Cost Plus and their wholesaler. And all the drugs come into Vermont through wholesalers of one type or another. These are just dedicated wholesalers that are keeping the price transparent, doing transactions, financial transactions that are consistent with the goals of Cost Plus and Civica, as opposed to these big national or global wholesalers. So I think it'll work. I don't think it would be confusing. They would work together.
This is more obtaining the medications, not the end purchasing by the consumer.
So, it's gonna be a while.
Yes, go ahead.
And what I think I'm appreciating is the interlocking aspect of all the pieces together. If we have transparency, we have it in the hospital and in all the other ways drugs need to be accessed. It seems like you have, you know, a more comprehensive interlocking system of saving on drugs, at least generics. I don't quite understand the impact of, you know, the main brands in all of this, but thank you for your work.
Yeah, and I was not aware that in HR1 there were things that were exempted. Surprise, surprise. What a shocker. Okay. Thank you. Thank you so much. Really appreciate you coming in with us today and sharing this. And we will have conversations and thoughts going forward. And thank you for all your work on this.
Excellent. Thanks very much.
Thank you so much.
Okay.